So we have a great opportunity again to learn about some new things, learn about some old things that maybe if you're in the addiction and recovery space, you know all about. But I'm always amazed to find people that are beginning to familiarize themselves with the whole process in which we treat addiction, chronic pain, and so on, and who aren't aware of this whole area of knowledge and people that are dedicated to helping others that have gone through the whole process of becoming addicted and now need assistance in entering into recovery. And this is a concept that we refer to as peer support. The people that are trained in this are called peer specialists. We have got two experts in this area that we're going to be introducing to you. The first one is Kimberly Falkinburg, who is a peer support specialist who has a nationwide focus on expanding access to peer support through training and lobbying and all kinds of works that she has through her organization, which is called Spread Hope Like Fire, which you'll hear a lot about. And then we have Jacob Levenson, who is the CEO of MAP Health Management, which is a network developer that helps people in the recovery area get access to peer support, transitioning from inpatient to outpatient, and helping them to maintain recovery through his systems approach. So we're going to start off with Kimber and let her take the talk away.
Good afternoon. Thank you so much for having me. And I just want to say, for those of you who have been here for 2 days in this room, first off, let's give each other a round of applause. And also to Dr. Dan Crow and his team. This has been a really great conference, really great summit, and good exchange of ideas, and I really appreciate the invitation. Like you said, my name is Kimber Falkinburg. I am the founder of Spread Hope Like Fire, which is a consumer advocacy group for people in and seeking recovery from substance use disorder, which is the strength-based language around addiction. I am a woman in long-term recovery from substance use disorder and a co-occurring disorder. I had concerns with depression early on in my life, and that untreated nature of those things combined with adverse childhood experiences landed me in the seat of having a substance use disorder. 1 second. That's much better. Okay, that's a natural fit. I, like many stories you've heard before, I'm sure, had a wonderful upbringing, a wonderful family life, and all the reasons and all the signs were pointing towards having a successful adult life. And in fact, I do have a successful adult life, but that is only because when I was employed as a project manager for a construction engineering firm in Pittsburgh, Pennsylvania, I had some excellent healthcare benefits. So when I was at the point where I was willing, able, and happened to ask the right person for help, so let's say that again, not only willing, but also able, and also ask the right person for help, then I was put into my employee assistance program, who then notified me of my healthcare benefits. I got the opportunity to enter into a 30-day treatment center inpatient here in Texas, and I am a born Texan. Also, I went to an intensive outpatient program for 6 weeks following that Following inpatient, I went to 6 weeks of outpatient. I then moved into what was at the time, just a few short years ago, 7 years ago, called a halfway house. Luckily, since then, we've started using more strength-based language, so we now call them recovery residences, by the way, or supportive housing. I lived there for the required stay, 90 days, and exactly on the 90th day, I left because nobody wants to live in those supportive housing environments. And I then followed the suggestions of the clinicians and the recovery support providers around me to move in with other people like me to have a lived, shared experience. And I maintained that sobriety and that lifestyle of recovery, through the first 3 years of my recovery in a town called Kerrville, Texas. It's just about 2 hours away from here. So since the date of my entry into long-term care for my substance use disorder, which was January 21st of 2011, I have had absolutely no mind-altering substances. I live a productive and healthy, wonderful life, and it is a result of the system that I was a part of, which actually in the state of Texas, only about 9.6% of people who need have access to. And I'm sure many of you have heard the stories of people who need treatment and aren't able to obtain it. In this state right now, for a male, single male, the wait is right around 142 days right now to get treatment in Texas. So you can only imagine how difficult that can be. Because we know substance use disorder is a chronic relapsing illness, we know that there's a lot of ways to treat substance use disorder. I've been involved in the National Recovery Advocacy Movement for several years now, and I worked diligently with a group of people on the national scale to bring attention to the epidemic in front of us, not just the opioid epidemic, but the substance use disorder epidemic and drug epidemic in general. We did a Unite to Face Addiction rally in Washington, D.C. on the National Mall in 2015. That was an amazing experience. We worked with the U.S. Surgeon General to create what's now called the U.S. Surgeon General's Report Facing Addiction. If any physicians in the room or anyone in the room has not read that report, I highly recommend you start in that space. It's a wonderful place to give you information on what we know today about addiction. A lot of the work that we know today about addiction was done by Dr. Nora Volkoff and her team at the National Institute of Drug Abuse. I work hand in hand with them. I now officially get to call them my science gang, which is really fun. I also work with the ONDCP, which is the Office of National Drug Control Policy, and of course, SAMHSA. Through those things, we created that report and put that out in 2016, I think. Maybe. And we did a lot of PR work. So much of what you see in the news today with regard to the epidemic and what we're facing is as a result of people like me with lived experience who started rallying and moving in a grassroots mobilized manner to get this conversation front and center. I understand that for the chronic pain patients, that has caused some difficulty. And for some people in this room, that has caused some difficulty. We're going to talk more as we talk more about the peer support role, about why that is, and how we are so excited that we got invited to this conference and this summit to have a balanced conversation around how chronic pain and substance use disorder don't have to be at odds with one another. We can work together, and I believe peer supports is the answer to that. And I used to Jacob and I are from the same hometown, Lubbock, Texas, and I actually worked for Jacob several years ago, so I'm a big fan of his system and what he does. So during the time that we were working on the national level, we also worked on creating the funding streams, making substance use disorders, specifically around opioids, more accessible, or treatment for those things more accessible. And I'm sure you've heard about the Cures Act and the $27.5 million that came to the state of Texas that has now created opportunity for medication-assisted treatment and services in the state. I would like to suggest that we maybe missed the mark a little bit from a state perspective on not requiring recovery supports with that medication-assisted treatment, because we do know and statistics say that medication-assisted treatment is highly effective, but even more effective when coupled with therapeutic services, including peer supports. And we have all kinds of data to talk about peer supports. One of the things that I was involved in the last legislative session, which is specifically pertinent to this conference, is House Bill 1486. We worked on that bill. It was the second time it was brought. I was a huge team of us, not just me, but we worked on a bill to create an opportunity for peer supports to become a Medicaid billable service in the state of Texas. We passed that bill, which is essentially, we never said this out loud. Yes, I've got some fellow peers in the room that worked hard on that and provided testimony at some of the hearings, so thank you for that effort. That was essentially a Medicaid expansion bill in the state of Texas that we got passed unanimously. So I think someone else said, how do you get a bill passed in Texas? And it's when there's no funding attached. I challenged that because we did it. It was hard, it was time consuming, it took many years. But it was a wonderful win. That billing status is not yet set. We're working on the rulemaking process now. It's expected to be done, we hope, by September of this year. So Now we have in the state of Texas around 2,000 trained peer recovery support specialists, and we're going to go into, again, we're going to dive into what all this means. What does it mean to be a peer recovery support specialist? But right now we have about 2,000 trained in the state and about 500 that are actually certified. There's a lot of opportunity here for us to all be working together, and there's many different ways in which we can do that. And again, how it relates to the chronic pain conversation, I have my notes on a very official little spiral notebook here. Peers, especially ones that are trained through the Peer Recovery Support Specialist certification, are not focused entirely on abstinence. So peers, by nature and by training, are focused on whole health wellness. We're actually provided all kinds of tools to do that, such as motivational interviewing, stages of change, and recovery action wellness plans. So we're having a different conversation when we talk about trained and certified peers versus someone with just lived experience. And don't get me wrong, and hear me very loud and clear. Utilizing peers in your system, wherever that may be, whether that's an emergency room department, in your clinic, in home health kind of services or community-based services, just because they have lived experience, is wildly valuable and extremely effective. If you add the certification and the training on top of that, now you have just a different ballgame. And that, I think, is a great handoff to what Jacob's going to talk with you about. So I just wanted to introduce myself. I'll be kind of chiming in periodically about what we're going to discuss, and I think that's all I have for now. I have a few other points, but I'll let you take it. Great. Thanks, guys.
Hi, I'm Jacob Levenson, CEO and founder of Map Health Management. I just want to correct Kimber on one thing. Kimber did not work for me. She works for nobody. Kimber and I work together and side by side. So, very good experience. I always like to open these kinds of discussions just to take a little sample from the room, because I think it helps put some things in perspective about where we are as a nation with substance use disorder and how serious and prevalent this chronic disease is. So I'm going to ask for a little participation from the audience. Raise your hand if you know anyone who was killed in the war in Iraq. Raise your hand if you know anyone who was killed in the war in Vietnam. Raise your hand if you know anyone who's died from a substance use disorder. We lose each year twice, and it's underreported, twice the number of people we lost in all of twice the number of Americans we lost in all of the Vietnam War. This is my generation's great crisis. This is hit in my home, in my community, in my friends, in my coworkers, and all of us are impacted by this directly through those we love, through those whom we share the community with, or through our social agreement we have with the country. So it's incumbent upon us, I think, to take the steps and the approaches that are the most efficacious into reversing the trends that currently, and not only with the opioid use disorder or the opioid epidemic, which grabs the headlines, okay, and kills in a dramatic fashion, but isn't the cost driver by a long shot. But it's incumbent upon us to find the most efficacious solutions to reverse these trends. And I don't think any of us set out, I wanted to be an archaeologist as a child. I didn't want to be a individual involved with the substance use disorder issue. In fact, I personally have run from this as long as possible. And like a Shakespearean play or a Greek tragedy, you run more into it. So I've kind of stopped questioning that and just accepted my lot in life here, which has turned into a privilege and a blessing to be able to impact this. And so to take this back a little bit, and let me stop for a minute because my style can be nonlinear, and the idea that I'm supposed to adhere and present off a set of linear slides is not something I'm liable to do very, very efficiently, but I'll do my best here. But let me take this back a little bit to the beginning and how we first began to use peers and saw that as an opportunity to drive improved clinical outcomes and financial outcomes for individuals with substance use disorders. Through a sister company who was still is, an acute care provider, we noticed in that setting that the RAs, the recovery advocates, almost always an individual in continuous recovery from a substance use disorder, that's who's in the trenches down in the typical addiction treatment facility. They're driving intake, they're helping discharge. It's the orderly, if you will. And something that individual has that is different from the clinical staff in that environment, which has a much more vertical and professional interaction with the individuals in that setting, is a horizontal alliance. And it is the glue that holds any acute care environment together when it comes to retaining people in the inpatient environment, stopping ASA, stopping AMA, those kinds of things. The RAs are the sergeant, the corporals and the privates in that environment. And what we also found is that simply longitudinal outcomes in how we're currently providing addiction treatment in the United States aren't acceptable. They're not acceptable clinically, they're not acceptable financially. And as Dr. Harmon said, how can you improve quality if you can't measure it? If we don't understand the phenomenon that's occurring in the post-acute world, how can we look for opportunities to intersect and to drive outcomes improvement? The only way that we have found to be able to have an impact on this population is through engagement. Longitudinal engagement for a chronic disease, a chronic relapsing and remitting disease that is terminal if left untreated. All the value propositions are generally a derivative of engagement. The peer, an individual in their own recovery from a substance use disorder who has a shared experience, whose approach is, Kimber, I know where you are because I've been there too. And there's this commonality and this underpinning of understanding and this trust that drives engagement and is not punitive, that is understanding and compassionate in how it's delivered. We have found, and this will be nonlinear, there we go. This is map data from our own ecosystem. This is from approximately 300,000 engagements that were peer-driven, all remote in nature, okay? Wherein peers are interacting with individuals who have left acute care. And this is looking at this through the lens of 12 months. And we're looking in the light blue being the member, if you're coming from a healthcare plan perspective, or the individual with SUD, and the darker blue being the consent, i.e. typically mom, dad, those whom we've received consent to interact with. And why that stakeholder constellation is so important with this population. In our own data, 91% of the time, in the event that the individuals return to active substance use disorder, it's the subscriber, it's the mom, it's dad, it's the spouse who is making the care acquisition decisions. Individuals typically in active substance use disorder have lost agency. They're not directing their own care when it comes to acute care most of the time. And what happens and how a lot of access is gained these days is 3 in the morning in a state of crisis on Google, addiction treatment for my son. And that is rife with many issues, and generally speaking, that's an auction environment, and it's not one wherein clinical efficacy or value or quality of care are aligning patient and provider. And it is a major factor in many of the issues we have. So not only, and the point I want to illustrate here is not only are peers critical for driving engagement with the individual, helping them adhere to discharge planning, helping them to navigate the ups and downs of early recovery, and I'll get into the tech enablement and the data enablement in a moment to drive predictive analytics and early intervention. But the peers' engagement with those consents is critical to drive more intelligent access of healthcare services, not just substance use disorder services, but helping ensure that this population, in one instance, one plan we're working with in the Northeast, whose SUD population, only 15% have a medical home. Whereas the holdout group, the non-SUD population, is running at about 46, 47%. And being able to drive the integration back into the medical side that we see ourselves 30 years later after a strategy of carving out behavioral health, where in 2018 we see the strategy of bringing all of the behavioral health carve out or large portions of it back in. So the peer's role in helping drive that coordination, which I think Dr. Harmon's presentation so adequately showed is critical. And what I was thinking when I was watching Dr. Harmon go through is if engagement is low, how do you affect the strategies of these models? How do you drive that impact? And the greatest value proposition, again, with the peer is the ability to drive engagement there. Now, what we see in how peers are driven and how we are able to empower them with data and technology and things of that nature, and to drive that engagement comes from a couple of different angles. One of the things that I find surprising, we constantly hear ourselves talking about telehealth and telemedicine. And I work with healthcare plans who continuously say they were let down in adoption rates or utilization rates of telehealth. Well, to us, telemedicine, telehealth, it's a medium, it's a tool to drive a certain strategy. And it's also something that is not going to be utilized if the individual on the other side has no buy-in. And in our experiences, what we've been able to find is individuals, and especially peers, who are able to drive easy, frequent connections with individuals in recovery using things like mobile applications, Bluetooth-enabled breathalyzers, other IoT like mobile applications, or an anxiety patch, which is, again, one of the leading early indicators to return to substance use is untreated anxiety, because untreated anxiety will be treated one way or another. And being able to harness the important and critical data that demonstrate wellness or lack thereof in an individual, and use the peer as a nexus and as an intersection point to grab that data and move that data around care collaborations to the stakeholders, be it PCP and other specialists, we have found to be a critical and function that the peer, the trained peer, can serve very, very well. With this, let us jump back in. Kimber, do you have anything to, is that mic hot?
Yep. Yes, I believe, wow, hold on. Yes, I believe it is very hot.
Sure.
I think I'll let you go ahead and then maybe jump in a little bit. But
Sure.
Thank you.
So let me bring this back for a moment, and then I'll turn back over to Kimber a little bit in my experiences with peers since 2011, way before peers in the substance use disorder space were cool or in demand, which we've seen a dramatic shift in the last 18 months, wherein there has been great acceptance in the utilization of peers, where historically, in my own experience, the peer model was a little early, so to speak. Being able to demonstrate the value of the peer to do some other critical things Dr. Harmon spoke about, drive emergency room reductions in the population they manage through a program with Aetna. We showed the peer managed population drove a 74% reduction in emergency room visits versus the non-managed population. The simple reduction of recidivism to a higher level of care. In various commercial environments, the ability to retain that peer when they are accessing resources within that healthcare plan's provider network. This is going to be hard to compete with. This is my wind down music here. But at any rate, the peer's ability to drive the reduction in utilization, to drive the access to more efficacious care, and to be a completely effective member of the hub and spoke and the ecosystem, and be a certified healthcare provider is very different than where it's been in the past. And what we believe and what we see and what we're a part of, both of us, in our respective approaches, Kimber, who is a known national advocate and certainly out driving change from the advocacy standpoint and the training standpoint, but on our side, from integrating peers into the provision of healthcare services, specifically with healthcare plans, that the adoption of the peer is changing, and we see an entire industry standing up that not only is efficacious for the healthcare consumer, the treatment provider, and the healthcare plan, but also creates a tremendous employment opportunity for people in recovery, which is a major factor in an improved outcome and is a major predictor for continued and continuous sobriety for people in recovery, which is meaningful employment. And the lack of access for employment opportunities for this population based on the punitive criminal justice system and how it approaches people with substance use disorder, or simply the stigma that continues to exist, has created many obstacles to the substance use disorder community to gaining meaningful employment and depriving them of the means to live a happy, healthy life and get the resources and access they need. With that, Kimber, let's chase some other rabbits.
Sure, yeah. Do you want me to just...
Absolutely. We can just kind of come up here and we can...
Or I'll just...
do your thing.
Chill? Okay.
Absolutely.
I wanted to talk a little bit about, I want to kind of relate it to kind of the chronic pain conversation and in an imaginary world where you're a provider or prescriber and you have a system where you're going, okay, but how do we even begin to identify substance use disorder? What questions do we ask? And then what do we do? I understand there's a lot of barriers, but it can be done. I mean, there are some really cool new tools out, such as the screening. It's called the SBIRT systems, which are screening and brief intervention and referral to screening, brief intervention, referral to treatment, SBIRT. NIDA just released some that one providers can use, one that the patient can use that's completely anonymous, and it's they do it themselves, self-assessment. There's a lot of tools out there to have this discussion, and I don't think that a primary care provider needs to become an addiction expert, but I do think that it would be appropriate for you to read through the U.S. Surgeon General's report, especially if you're prescribing controlled substances that are highly addictive, and familiarize yourself with the new information about addiction, especially the fact that it is a chronic relapsing illness and not necessarily a question of choice or moral failing for an individual or your patient. Once that an individual, through whatever means that you identify, may or may not have a propensity to misuse one of the substances that you're prescribing, or in a better manner, you're utilizing some of the cool technology, like my friend over here who has a new addition to the PDMP, and you're really looking at, from a clinical perspective, what's appropriate for prescribing, and you think that the next level of support might be needed, I would suggest that you consider utilizing peer services in that way, whether that's through a telehealth model or a community-based program, not that those two can't be combined as well. I think that what you will find with peer workers, or especially trained and certified peers, is they are some of the most connected and well-resourced individuals in your community. It's our job to be. So when it comes to the neighborhood conversation that was just discussed, they know every provider on the list. I'm talking about LPCs. I made a list of like who I use on the regular, or the coaches that I supervise on the regular. LPCs, sound therapists, yoga practitioners, medication-assisted treatment providers, traditional SUD treatment, meditation teachers, smart recovery circles, a Buddhist pathway of recovery known as refuge recovery, that's rising up in Texas, finally. We have church groups, supporting housing groups, chiropractors who are doing great work in chronic pain management. So the peer specialist really can be that neighborhood watch person, if we're going to use that analogy. I do, again, want to just really drive home any providers or prescribers who are taking the training and what is it called tomorrow?
DE waiver.
Yeah, the DE waiver training tomorrow. I would really encourage you to reach out to us and get some information about this peer specialist role, and how, when combined with the treatment, the medication that you're providing, can be an incredible combination. And in my opinion, absolutely best practice. I think a lot of people around the country would agree with that. And then lastly, I want to go over, which I think we talk about in one of these, I want to go over what it looks like to become a trained and certified peer in the state of Texas, which is very similar to other states. You start by, first, you do require that you have to have at least 2 years of sustained recovery. Following that, you take a 46-hour training provided by the state, created and provided by the state, or other really great training providers that come in from out of state or other programs. Following that, the individual then does 25 hours of clinical supervision, or supervision by someone like myself who's been doing this for quite some time. After that, they do 500 hours of practicum experience, so that's either volunteer or work experience. They take a test, which is provided by ICNRC. The same test is provided for all of the states across America. And then they're certified by the Texas Certifying Board of Addiction Professionals, or National Association for Addiction Professionals, so on and so forth. So these are folks who've really made an investment in not only their time, but oftentimes also their money to get to the point where they're ready to work inside your system. So when I say certified, trained peers, we're talking about people who really have a pretty good foundation behind them.
I think we have 2 minutes. Do we want to give an opportunity for a question or two? I think Kimber and I went, please.
Yeah.
We have troves of that data. We don't have it in this deck.
Yeah.
But what I will do is I'll get your contact information, and I'll have someone from our team distribute that information around. If anyone's interested in receiving this kind of utilization data,
and
let us know.
There's also, in addition to the data that MAP has, the University of Texas just wrapped up a 3-year data collection and research paper on peer supports in Texas. We were one of the first states to really deploy this across a massive state effort.
Yeah.
It's really great.
Sir?
Do you have any peer support specialists that can help with adolescents?
I'm so excited you just asked that. So I helped write the curriculum for young adults in Texas, and I recently just traveled up to get the nation's first adolescent recovery coach training curriculum from Connecticut. So we're working on it. We're getting there. Yeah.
Maybe we'll try to do these quickly. Sir in the white shirt?
All right. The PRSS engagement slide you put up there?
Yes, sir.
First time I've seen that, I don't understand the denominator. What are you telling me in that slide?
So what I am telling you is the bottom values are months 1 through 12, post-acute, so leaving an IOP or above level of care. And what we're looking at on the light blue side are the percent whom remain engaged from that population with their peer recovery support specialist. So for instance, in month 1, just under 50% of the discharged population remained engaged with their peer. The darker blue is, again, just under 50% remained engaged. Parents, others who are stakeholders of that individual in recovery remained engaged with the peer as well.
So if I could just piggyback on that very quickly, which might help you as well. What we're talking about is we have created a system, which I don't necessarily agree with, where when a person identifies as having a substance use disorder of any level, they get put into a 30-day inpatient treatment center, and that's an acute care. That's what he's talking about, acute care facility. He's talking about adding the peer support specialist service post-discharge from acute care and how long that patient engages post-acute care. So there's a lot of ways to look at that, but this is excellent data. Yeah.
On the slide, it says, divided by the total number of attempted sessions. It doesn't say individuals, it doesn't say discharge data, and that's what's confusing.
Well, I'm going to come right back to this table when we're done, and I'd love to sit down and kind of run through that information with you. Absolutely. So I think that we've just hit our stop. And anyone else who has questions about this, I'll make myself, Kimber, available. Kimber, you just want to come to this table?
Sure, yeah.
And is that okay?
Perfect.
Okay. Thank you, everybody. We really appreciate your time.
Yeah, thank you.
Thanks, sir.